Hello, and welcome to my poster presentation on the association between Crohn's disease and the incidence of congenital anomalies. The existing literature on this topic is largely mixed, and many studies actually show that there is no increased risk of congenital anomaly in the setting of Crohn's disease as summarized in Figure 1. These studies do, however, talk about other various pregnancy complications and their link to Crohn's disease, such as preterm delivery, low birth weight, preeclampsia, among other things. Many pose the hypothesis that these are related to disease severity, and some actually show data that when patients are having a disease flare or more severe disease, they are more likely to have these complications of pregnancy. It is likely that these disease flares and increased disease severity is also playing a role in the development of congenital anomalies. While there is limited literature on the mechanisms that may be at play here, there is a little bit of literature on what maternal inflammation can do to a developing fetus. And it has been shown that maternal inflammation can be detrimental and cause fetal malformations. There are also several studies showing that maternal cytokines and inflammatory mediators can cross the placenta, and we know that these can be detrimental to the fetus as well, which may cause these fetal malformations, as summarized in Figure 3. In this retrospective cohort study, we used a national database of 53 million patients. These patients were then filtered by those with Crohn's disease and without by ICD-10 codes. These patients were then matched to each other, the Crohn group and the control group, based on age and Charlson Comorbidity Index, yielding two groups of 70,000 patients approximately. These two groups were then analyzed to figure out how many patients in each of these groups had given birth to children with fetal anomalies, yielding 816 patients in the Crohn group and 666 patients in the control group. Looking at Figure 4 now, these data are statistically significant with a p-value of 2.2 times 10 to the negative 16 and an odds ratio of 1.77. In Figure 5, we actually have the breakdown of these various anomalies by the site of anomaly in the fetus. While the control group's most common anomalies were related to the skin, the Crohn group actually had more anomalies in the intestine. Overall, these data do suggest that there is an increased incidence of congenital anomalies in children to women with Crohn's disease when compared to their matched control counterpart. As far as the increase in intestinal anomalies specifically, there was one study that evaluated the impact of maternal inflammation in mice. This study did find that there was an increase in the incidence of intestinal anomalies in mice that were exposed to maternal inflammation in utero. While they didn't pose any specific mechanisms that they were aware of that could cause these intestinal anomalies in this study, it is quite possible that a similar phenomenon that was happening in these mice is happening in humans when they're being born to mothers with Crohn's disease. This study largely uses ICD-10 codes because the ICD-9 does not provide specific coding for Crohn's disease, rather enteritis. So we believe that makes this study very strong, recent, and specific for Crohn's disease and its association with fetal anomalies. Also, several of previous studies did not include a matched control group, which we also believe to be a strength of this particular study. One limitation of this study, however, is that it is reliant on the accuracy of ICD code input by the physicians that are practicing and whose data is in this database. While we can see that this data is significant statistically, we still question what the clinical significance of this data may be. More work is needed in order to determine if there is any reason to increasingly screen mothers with Crohn's disease for various fetal anomalies given this data. Thank you for your time, and you can find my references at the QR code below.